Hi Thrivers, welcome, and we appreciate you joining in with us tonight. I'm Lori Buckley from Natural Therapy, and this is Rachael Schmidt from Nebraska Medicine. And tonight Rachael is going to speak with us and give us some tips on how to manage your side effects from your cancer treatments. So we're excited to hear that, so thank you for being with us.
Of course. So I'm Rachael Schmidt, and I am a nurse practitioner at Nebraska Medicine. I run our cancer survivorship program there, and like Lori said, I'm here to talk about managing your treatment-related side effects. This is a very broad topic, so I'm going to try to hit the high points on multiple different treatments and what can cause those side effects. And I always like starting out with a little bit of background information. So first thing is, who is a cancer survivor?
So before Rachael gets started though, I'm going to let you know that she's going to talk for about 20 minutes, and then we want you guys to send in your questions for that. So feel free to go ahead, and you can be sending in the questions already now as we get going, because we want to make sure we cover as many of them as we possibly can for you. And you know, I've talked to Rachael a handful of times, and one of the things I love about her is not just her compassion, which you're going to see, but that is her true heartfelt desire to make your cancer journey a smoother, better, easier journey. And I love that about her, because she doesn't just talk about the change, she is a change maker, and that's what I love. And she makes a big difference. And so she has started a additional survivorship program at the Nebraska Medicine, and so she will speak a little bit about that as well. So go ahead.
Yes. And I jumped the gun, so I apologize.
No, that's great. It's great.
All right.
She's so excited. Yay!
Ready to go. So first thing that we're going to do is just kind of go over who is a cancer survivor. I feel like there's a lot of different definitions out there, and my goal is to redefine the definition, make sure everyone is aware that anybody is a cancer survivor the second that they're diagnosed with cancer through the rest of their life. So that includes everyone. And the reason why I like to make this aware is because that affects cancer survivorship. And cancer survivorship should really start at diagnosis. There's multiple things that we can address at the beginning, such as fertility preservation, sexual health counseling, and other things that we'll get to in a second. But we have kind of not been as proactive about integrating survivorship at the beginning, so that's just why I point that out. When we talk about late and long-term effects, there's two different types out there, and it's really dependent on when you experience those effects. Late effects happen after cancer treatment has ended. So you go through treatment, you didn't experience an effect then, but a side effect will come up either months or years down the road. And then long-term effects are when you have, say you're going through chemotherapy and you have peripheral neuropathy. That happens during cancer treatment, and it can persist for months or even years after treatment. So those are the two differences, and I will use those terms interchangeably, but the difference is when they happen to you. So the first thing that we're going to talk about is late and long-term effects regardless of any type of treatment that you get. So this can happen to anybody that's had a cancer diagnosis. And the most common one is fatigue. And in my practice, I would say over 90% of patients have some level of fatigue, whether it's just mild fatigue, they have a little bit less energy than when they were initially before diagnosis, or they need to take a nap every day because they're incredibly tired. They can't do the normal things that they used to do before their diagnosis. One of the things with fatigue is a lot of people think that they need to rest more during treatment to help preserve their energy. And that is true, but there's also a lot of evidence that says if you are exercising during treatment and after, your levels of fatigue go down. And exercise helps promote your energy, so I try to tell patients, stay active during treatment, and if you're feeling tired, keep up the physical activity after treatment, even if it's doing 10 minutes a day and then slowly increasing to where we want you to be, which is around 30 minutes most days of the week. The next one is anxiety, depression, fear of recurrence. I feel like this is something that is underdiagnosed in most patients. And when you go through a life-altering change, like getting a cancer diagnosis, everyone's going to have new anxiety and depression and fears. Even months or years after treatment has ended, they always just have that little worry in the back of their head. And one of the best things that we can do as providers is continuously screen for this throughout diagnosis through the end of your life. This can come up many different time points. So one of the things that we should be doing is asking about it, but we also want you to tell us. So if you are having new thoughts or things are bothering you more often, please speak up to your providers because it's something that we need to know about in order to help you. Things that we can do are start medications, such as antidepressants, anti-anxiety medications. But we know the best treatment is when we do medications with cognitive behavioral therapy. So that's counseling. And one of the things that we can do there is get you set up with either a psychiatrist, a psychologist, a mental health therapist, or even teach you how to do some of those things on your own. And when we teach you the cognitive behavioral therapy, you have skills that can last you a lifetime to help improve how you, like when thoughts come up, it will help you try to get rid of those thoughts on your own. So that's one thing that I always try to encourage people to do.
I think that a real important thing there that Rachel said was that everybody experiences it at some point in time. So you should never be embarrassed or feel ashamed or feeling like you don't have it together because you're feeling any of those issues. They are normal, but they don't have to be your normal. So don't ever be ashamed to speak up about those.
Nope. And I actually recently had somebody come in that was 5 years out of therapy, 5 years out of treatment, and they were still having lots of fears of recurrence, and we had to work really hard to get those fears under control so she could get back to living her normal daily life. Another thing that cancer survivors all experience or have a risk for is a secondary cancer. And this is because the treatments that they have. So chemotherapy can increase the risk for a second cancer like leukemias. It's very rare, but that risk is there. Having radiation can increase your risk of a breast cancer. Also another skin cancer and some in angiosarcoma, different things like that. And then there's always people that have genetic mutations, which puts them at higher risk for multiple different cancers based on their type of genetic syndrome. There was also a study that came out that said with people that were diagnosed with cancer, 25% of them had a previous cancer, so there is that risk of increased cancer with one cancer diagnosis. And I don't know if you guys pay attention to celebrities, but some people that you may recognize that have had multiple types of cancers are like Robin Roberts, who initially had a breast cancer diagnosis, was treated with chemotherapy, later developed MDS and needed a bone marrow transplant. So that's just one example of a chemotherapy causing a secondary cancer. And then last one in this group is cognitive dysfunction. I previously might have put this under the chemotherapy-related side effects, but we now know that cognitive dysfunction can happen with anybody regardless of chemotherapy. So we like to refer to it now as brain fog instead of chemobrain. So that can happen in up to 75% of patients. The best thing that you can do here is try to write down notes, set reminders, try to do brain stimulating activities such as word puzzles. Some people like to do luminosity just to keep their brain stimulated. Reading's really good, crossword puzzles. But those are the things that we help or try to encourage patients to do on a daily basis. But if you notice that your memory is getting worse, we can always do a neurocognitive evaluation too. So the next group of late effects out there is ones that are from chemotherapy. One that I like to talk about and not a lot of people think about is the cardiac risk, because usually this happens 10 or 20 years down the road. And the reason why I bring this up is because a lot of the drugs that people get from chemotherapies, like doxorubicin, Herceptin, Perjeta, they all have this cardiotoxic effect. So this just can damage your heart muscle long term. So what I talk about with all my cancer survivors is we need to be aggressively managing your cardiac risk factors with your primary care provider. So making sure your blood pressure is under control, making sure that you get your cholesterol checked every year, that you're not smoking, you're eating healthy, you're exercising. Those are huge in maintaining your cardiac function well. And we actually have a new group at Nebraska Medicine, and I believe he talked with you guys before.
Yeah, Dr. Stone.
Yes, yeah. So
yeah.
he started our cardio oncology program, and him and I partner a lot. So if we see that patients are having elevated blood pressure or elevated cholesterol, we'll get them over there to help aggressively manage those risk factors. Another one is chemotherapy-induced peripheral neuropathy. So this is with taxanes most often, or Taxols, and this is numbness, burning, pain in your fingers or feet. And with this one, we typically say that this will happen during chemotherapy and hopefully go away as time goes on. So usually patients will say that hopefully by like 3 months it'll start lessening. If 2 years you're still having the pain or numbness, that might be what you're stuck with for the rest of your life. We're trying to make sure you can hear me, so I apologize. But a couple things that we do to treat this is we can give you gabapentin, which is something that we used to do a lot in the past. Sometimes that can help patients, sometimes it doesn't, no matter how high we go. But a newer drug that's actually more effective now is Cymbalta. That's actually an antidepressant, and this one has been shown to be better than gabapentin. I also like it because it has less of that tired effect or drowsiness effect, and so that way, I mean, patients are already fatigued, so why would we make them even more fatigued by giving them gabapentin? And with Cymbalta, we also could touch on another side effect, which is the anxiety and depression, so we can kill two birds with one stone there.
I do know that one of the survivors who have registered, one of the questions they asked when they registered, is there any way to help with that peripheral neuropathy without either one of those drugs?
So, that's a good question. I feel like peripheral neuropathy is one of the hardest things to treat, especially if it's been going on for a long time. There is newer evidence coming out that acupuncture may help, so I always say try it. It's low risk. If it helps, great, keep doing it. If it doesn't, then you can usually stop, and you won't have a lot of side effects.
Yeah.
And then exercise is always a good thing to help as well. Another thing I try to tell patients is make sure that we screen you for diabetes, because if you have underlying diabetes, that can make the peripheral neuropathy worse as well. So that's all I got on that one. Infertility is another side effect that can happen from chemotherapy, and usually the best thing that we can do is help do fertility preservation ahead of time, but it all depends on the type of treatment that you're getting, the dose, how old you are, what your baseline fertility status was to start with, and other personal risk factors that would affect your fertility. This is something that we work with reproductive endocrinologists on, and we collaborate there. We get patients in quickly to help do like egg preservation ahead of time, and we're really trying to encourage our medical oncologists to talk about it with anybody under the age of 45. So this is something that we really need to do, because we want you to be able to have the choice if you want a biologic family in the future. And then the last one is hair loss. And with chemotherapy can come hair loss, as everyone knows. I feel like everyone worries about that when they get diagnosed with breast cancer, and that's one of the first questions is, will this chemo cause hair loss? And the reason why you get hair loss is because hair, nails, skin are rapidly growing cells, and so is cancer. So when you use chemotherapy, we want to target those rapidly growing cells. And with hair loss, I feel like our patients, it weighs on them because then it kind of takes away their privacy in having a cancer diagnosis. And so that's something that everyone struggles with. They worry about if their hair is going to grow back the same. One thing that we're doing at Nebraska Medicine is we actually have partnered with Paxman scalp cooling. So this is a system that you put on your hair during chemotherapy treatments to help try to preserve your hair throughout treatment. It completely depends on the type of regimen that you're getting, as well as how well people use it, and if they're coloring their hair, if they're brushing their hair, all those different types of things. So it can vary from person to person, but it can range in retaining your hair anywhere from 20% all the way up to 85%, which is good. And then the next one is surgery and radiation. I paired these together just because I feel like they have the exact same late effects. A common one is lymphedema, and this is the swelling in your arm because you had lymph nodes taken out or radiation to the lymph nodes. Your risk is totally dependent on the number of lymph nodes taken out as well as the radiation treatment that you've had. So it can range anywhere from 5% to just having a sentinel lymph node biopsy up to 35% because you've had an axillary lymph node dissection plus radiation to your axilla. So that's a big range. It also is completely dependent on your body weight to start out with and if you gain weight over time. So when people gain weight, their risk of lymphedema goes up. One thing that I will say is we want to know right away if you feel any swelling, heaviness, clothes fitting tighter on that arm. And the specialist is right over here for lymphedema. Yes, so that is her area of expertise. Do you have anything to add there?
Most of the time it's before you even see the swelling. It's just really heavy and achy at the very beginning. You don't really see the swelling. It fatigues very quickly on you and it's very, very achy. So those are the beginning signs we want to talk to somebody about it right away. It doesn't have to be just your arm. It can be, you know, kind of from your armpit to where your bra line goes, or even just your breast. It could be one of those areas or all of those areas. It doesn't have to be just the arm. So if you're feeling that even just in your chest, then you should talk to your physician about that.
Yep. Early identification is the best thing that we can do to help get you into the therapy that you need with someone like Lori. The next one is body image, and this is because people have mastectomies, they might have radiation that might change the size of their breasts, scarring, loss of a nipple, all of these different things can change how people look at themselves and their body. They might feel less as a woman because they don't have breasts anymore. They might not have the same sensation. These are all things that we discuss, and we have oncoplastic surgeons that can work on with that. But a lot of it is also with therapy and talking about that. So again, cognitive behavioral therapy is a mainstay there. And then the last section is on endocrine therapies. And I feel like this is where I'm going to get a lot of questions because everyone has side effects with these. Most breast cancer patients, all ER, PR positive patients are on some type of endocrine therapy for at least 5 years, if not 10 years. That all depends on your type of tumor and staging and your doctor's orders. So I'm not going to tell you how long you should be on it, but we'll talk about the side effects. The most common one is hot flashes that I hear about with my patients. And this can be hot flashes or night sweats. what I talk about with them first is that with all these side effects, the symptoms, the longer you're on it, usually the symptoms start getting a little bit better. And hopefully. And then lifestyle interventions make a world of a difference. I will probably repeat myself a few times, but exercise is probably the number one thing that you can do to help with hot flashes, joint and muscle aches, sexual dysfunction. So you'll hear me say that a few times, but in particular with hot flashes, try to limit your caffeine. That can increase the risk. Try to limit alcohol before bed. Alcohol can trigger hot flashes or night sweats throughout the night. Use fans, wear layers so that way if you start having one, you can take a layer off. Again, exercise is helpful. We do have medications that treat hot flashes, such as Effexor or gabapentin. Again, I try to limit that because all medications have their own list of side effects, and I try to save that for patients that are absolutely miserable and need something to help control that. And then there's, again, newer evidence that acupuncture can also help with hot flashes. And then there is sexual dysfunction. And this is something that goes underreported, but in the studies, around 40 to 100% of women experience some type of sexual dysfunction, whether that's vaginal dryness, pain with intercourse, vaginal discharge, usually with tamoxifen, or decreased libido. And I just like to tell everyone that sexuality is a central part of being a human, and that it 100% matters, and that we know that if you are having sexual dysfunction, it can negatively affect your quality of life as well as your relationship with your partner. So please tell us. I know that it's super uncomfortable to talk about this. Patients don't like bringing it up. Providers don't like bringing it up. It's all over the research or in the studies. But in survivorship visits, we bring it up every single time. So I'm very comfortable talking about this. So if you have questions, ask me. Usually with vaginal dryness, we recommend lubricants 3 to 5 times a week. This can be Recurrence. It can be coconut oil, which you probably have in your kitchen. It can be multiple different things. With intercourse, if you're having pain, we usually recommend a lubricant with intercourse. It's not going to be the same as Recurrence or the coconut oil, but something water-based every single time. And actually, the more times that you have intercourse, it is better. It helps with that pain. If it's pain with insertion, we will talk about dilators because the dryness has thinned those walls, and we'll go down that path as well. If none of those are working and you're still having a lot of issues, there is research out there that does say that some local estrogen can help with these sexual dysfunction symptoms. And we do prescribe it because we know that this is a very important part of maintaining your quality of life. So we like to do those other things first, but if it gets to the point where none of that's helping, we can do estrogen tablets or cream. Is there a question?
We have lots of questions
Okay.
coming in, so.
Okay, I'm almost done. And then there is joint pain and muscle pain. I feel like everyone complains about this the second that they wake up in the morning. First thing that I tell people is usually it'll go away with exercise. So if you can, try to exercise in the morning and hopefully it'll get better. As time goes throughout the day, you can always try to use Tylenol or an ibuprofen to help alleviate the pain if it is bad. But they also, again, I feel like I'm repeating myself like with acupuncture, but there is evidence that acupuncture can help with this as well. And then the last side effect that I'm going to talk about with being on an endocrine therapy is osteoporosis or osteopenia. We know that being on an aromatase inhibitor, so letrozole, exemestane, and anastrozole, I just almost blanked on those for a second. All 3 of those are in the same family, and what they do is they block the estrogen that's in our body. So as women, if you are naturally going through menopause, you're going to be at higher risk of osteoporosis anyways, and by us blocking any additional estrogen, you're going to be at higher risk. So we're going to do bone densities every couple of years to make sure that we're not pushing you into osteoporosis. We would recommend you taking vitamin D 2,000 international units per day or more, depending on your vitamin D level. And we want you to do weight-bearing exercises such as walking, weightlifting. You can do air squats off of a chair, anything to help build up that bone and prevent it from thinning from the medication we're giving you, and being a woman and aging, unfortunately. But I will go to questions,
All right.
and then we can talk about some other stuff.
All right. They might all just kind of come up with your questions.
Mm-hmm.
So these are questions that have come in from you ladies. Please address heart failure, skin prickles, primarily on my back when it's hot. My nails are split parallel to the sides, my fingers from the tips down into my cuticles. So the nail care thing is tough. What do you have for?
The nail care thing is super tough. I honestly, with my patients, sometimes we just tell them to try to take biotin. That usually helps. There's not a lot of evidence saying that it's bad. I haven't heard of any personally. And then I have heard some of our doctors say that it's okay to do like the hard as nails type thing to help with the splitting and help strengthen them. You said heart failure?
Yes.
Okay. Heart failure, that would be like the cardiotoxicity that we're talking about. So if you've had doxorubicin, which is the same thing as adriamycin, that can happen 10 or 20 years down the road. If you have Herceptin or Perjeta, that usually happens, or heart failure can happen during treatment. So while you're going through those treatments, if you're HER2 positive, we would recommend an echocardiogram every 3 months during that treatment to screen for any ejection fraction drops. So that's the function of your heart and if it's not pumping efficiently. And if there's a drop, we either would have to do like a dose change in your treatment or skip a treatment, send you to cardio-oncology so they can put you on different types of medications to help improve your cardiac function. It all depends on your cardiac risk factors too. So it's all very individualized.
So it's just part of the preventive for the whole heart failure. What you said earlier in your talk, it's really like good exercising, the diet is important, watching the cholesterol, and then just getting your blood work done on a regular basis as far as preventative stuff. Yep,
so we would recommend all heart healthy guidelines out there. And actually that's kind of what I was going into with my next part is we want to improve all lifestyle behaviors, so that would be exercise at least 150 minutes per week, a diet rich in fruits and vegetables, don't smoke, that can increase your risk for heart disease and cancers, multiple cancers, so please don't do that. And then making sure you watch your blood pressure and watch your cholesterol. Another note about cholesterol is anastrozole, letrozole, exemestane, all of those can increase your cholesterol, so making sure that you get that checked once a year is important as well.
I know it's really hard to exercise when you're really fatigued, so there's no doubt about it, but you know, exercise is a vague, I mean, it can mean many, many things. So it doesn't have to mean going to yoga class or riding a bike or getting outside and walking. It could be simply, you know, if this is where you're starting, sitting in the chair, just doing this, you know, anything you need to get those joints lubricated and just to get them moving to start the blood flow, and it helps fight the fatigue for you there too.
There's actually evidence out there that says exercise can be walking, like really anything, but just sitting less is more important. We are just so sedentary in the US that we have had tons of studies come out saying that as long as you get up and move every hour, whether that's just walking around the house, like Lori was saying, doing some small exercises or easy exercises in a chair. You can do it with cans of food, whatever you can do.
Dishwasher, that bend and reach. Yeah.
Something that's just outside of your normal daily activities is considered exercise.
So here's another question. I'm taking Cymbalta and gabapentin. It helps with the peripheral neuropathy, but it numbs the entire body and the emotions.
Yes.
So then do we have to take another drug to deal with that, or?
No.
Okay, good. Yay, good answer.
Again, like I said, in my patients, I try to limit it as much as possible with putting more people on medications to correct side effects, because then you have to deal with the new side effects of that medication. If it's helping your neuropathy, great. Maybe try scaling back on the dose, because it might be affecting your mood too much. Try adding in some of these lifestyle interventions like exercise, maybe try acupuncture so you can try to scale back on the dose, and hopefully that'll help. If it's numbing you, you're probably on too high of a dose. And maybe counseling could help as well there.
That's good to know. Can Cymbalta cause weight gain?
Yes.
And are there substitutes for the drugs that do cause weight gain?
So, weight gain is common with all antidepressants. It doesn't happen in everyone. A lot of the time, like with Cymbalta, with Effexor, I try to keep everyone on the lowest dose possible, which will reduce your side effects, including weight gain. Anastrozole, or all of the endocrine therapies, and tamoxifen can cause weight gain too. They say between 5 to 10 pounds. That's why I try to encourage everyone to exercise as much as possible to help offset some of those weight-related side effects. I try to tell people, I'm trying to explain this without making it sound like a terrible drug, but I know it causes a lot of side effects, but we don't want you to not take it because there's a potential for weight gain. I know a lot of women are very weight conscious, and so they hate hearing that side effect, but we also want you to be aware that this drug can have huge benefits on reducing your risk of cancer recurrence, so that is so important in the long term, and there's lots of things that we can do to help manage weight gain as a side effect.
How can a person sort out what is an effective treatment versus normal aging versus is this a side effect of my treatment? Am I having joint pain just because I'm getting older? What the heck?
That's a good question. It depends on how bad everything is. Sometimes I go through these trials with patients where I'll be like, we can stop your anastrozole for a month, and if everything resolves, then we know that it was because of your medication and not because of age-related changes. And then we can pinpoint it a little bit more. Some other things that we can do is, if it's the pill that you're on, we can always switch it to a different one. But I kind of like to tell prep patients that it's kind of like Russian roulette. We don't really know what we're going to get with the next one, because all of them have the same profile of side effects, but how they metabolize in your body or what side effects you get from each one is completely different. So you might not have any side effects with anastrozole, but you might have hot flashes and sexual dysfunction with letrozole. Or you might not have any of those with letrozole. It's a guessing game.
So, my hair is thinning because of my drugs. Mm-hmm. Will it always be that way?
Maybe. Potentially. And usually hair thinning is very, I don't know how to answer this question the easiest way. I think hair thinning is a very rare symptom. I don't see it a lot in my patients. We could always you could always talk with your providers on switching the medications. I've seen some patients actually use Rogaine to treat some of their hair thinning, which is fine. I personally haven't used it or recommended that for any of my patients. But after you stop the drug, it should come back to how it was. I know that might be years down the road, so it might not be a easy option right now, but it's something to consider.
The commercial for hair growth, you know, where you just put it on, does it work?
No, not really.
Okay. I got new glasses last year, but my vision seems to be getting worse. Can this be related to tamoxifen or hypothyroidism or aging?
I would say it totally depends on the type of treatment that you had. Any type of chemotherapy can cause some visual changes or worsening eyesight. Tamoxifen can increase your risk for cataracts, so we do recommend that you get your eyes checked at least once every year to make sure that there's no new vision changes. Age definitely plays a role in that. So I just tell people follow up with an eye doctor once a year and make sure that there's nothing going on, or to renew your prescription.
I have retinopathy and developed type 2 diabetes during treatment. That's still under control, but I'm still experiencing the retinopathy.
Does she mean peripheral neuropathy?
Yes.
Okay.
Probably.
Okay. So for peripheral neuropathy, and it says she's still having it.
Mm-hmm.
Okay. So again, with peripheral neuropathy, I think that there's several different things that we could try. Try exercising. Make sure that your diabetes is under really good control. Try acupuncture if you want to do a low risk treatment. We have the option of doing Cymbalta or gabapentin. Those are things that you can always bring up with your doctors as well.
I'm experiencing joint pain in my hands, which is an unexpected side effect of aromasin. Are there any effective natural remedies?
So, like we talked about, exercise. I'm sorry, guys. I'm like a broken record. Exercise is the best thing that we know. So if you can, first thing when you get up, try to do some type of exercise. Again, what that exercise is variable on what you want to do, what you like to do. If you like to do yoga, that's a great form to help with joint pain. If it's really bad, you can always take a anti-inflammatory medication, but those are probably the best things that I would recommend. Or again, acupuncture. Mm-hmm. You can try it.
We did do a straight talk series on acupuncture, and ladies, you can find that on the Project Pink website. And you know, during that straight talk series, she did talk about several of the things that Rachael is mentioning, that it does help with hot flashes and the joint pain, and for some people, nausea. Mm-hmm. It was helpful for that, and the insomnia, mm-hmm. and those kind of things. So the peripheral neuropathy for some women too, and then just even the fatigue and anxiety, because it's a very calming, relaxing thing. So if you want to see a little bit more about that, Maureen from River Point Acupuncture did a straight talk on it, so you guys can look at that too. So that's one of the next questions, insomnia.
Okay, yes. I think that can happen for multiple reasons. Usually I like to ask patients, like, are you able to fall asleep or are you having trouble falling asleep or staying asleep is kind of the first questions I always ask. Is it anxiety that's driving this? Is it fear of recurrence? Is it or night sweats or hot flashes that are keeping you up? Do you have sleep apnea? Those are all different types of things that I like to rule out with patients. Having a good sleep hygiene is really important. A lot of us don't. I know that this is something that I try to work on all the time, but getting into a routine, making sure that you shut devices off at least 30 minutes before bed, those are things that we try to encourage, make sure you don't drink any alcohol like right before bed, because that will keep you up or not let you fall asleep as easy. And then other things I recommend that are kind of natural is melatonin. I feel like that doesn't really have many side effects, and it's something that is easily something that you can incorporate. And the trick there is to take it at least 2 hours before when you want to go to bed. I feel like people take it too late and they expect it to kick in really fast, but it actually is, when I have been shadowing providers in the sleep medicine department, they say at least 2 hours before bed.
And another thing too with that is the fatigue. If you're someone who fights the fatigue and you're doing lots of like tiny little cat naps
Right.
through the day, or even if you're not really cat napping, but you're just not doing much of anything during the day, then that can also create insomnia. So again, it's Rachel's word of exercise.
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 Yes, because when you sleep throughout the day, you really mess up your sleep-wake cycle. And so we just need to get you back on that normal cycle of sleeping at night and staying up during the day. Try not to take naps past 1 o'clock is like the golden rule to help preventing insomnia.
And how about those who are suffering vertigo? Have any?
So I honestly don't deal a lot with vertigo because I don't have a lot of patients that deal with it. I usually refer them to our, oh my god, I'm blanking on the name of it, but it's a physical therapy place that deals with vertigo, because that is not my specialty. I'm sorry.
That's right.
Yeah.
How about UTIs, frequent UTIs?
Sometimes that happens because of chemotherapy. I don't know about any other causes. I'm just trying to think off the top of my head. But frequent UTIs, usually sometimes vaginal dryness can cause it too. So making sure that you use a vaginal moisturizer. We do partner with one of our urologists as well as gynecologic. I cannot talk today. Oh my gosh. You know what I mean? To help rule out that out and treat those. But I don't typically treat UTIs either.
How about, is it possible to prevent any of the side effects of these medications other than exercise? Just thought I'd rule that one out before you said yes, exercise. In general, like when you start cancer treatment, you know that you're going to be on these drugs and this is the list of possible side effects. Is there any way to be more proactive so that you can prevent some of those things from happening, or is it just really the luck of the draw?
I would say it's 100% the luck of the draw. I will, again, push exercise because if people or patients that I've had that have been active throughout treatment, say they have been exercising, whatever that may be, through their surgery and chemotherapy, and then they start one of these endocrine therapies, they honestly have had minimal to no side effects, and that is like the best thing that I can hear because I know how hard it is to treat some of these things, and to know that it might go on for 5 years. I just am happy when they're not having any symptoms, and it's always the ones that have been exercising from the beginning.
So how to better manage my side effects and possibly learn the difference between normal and abnormal side effects? That's an interesting question. I get that a lot from my patients too. It's like, I'll say, well, why didn't you mention this to your doctor? And they're like, well, because it's just a normal side effect. But just because it's a normal side effect to the doctor because he's heard like 36 people today complain about the very same thing does not mean that's normal for you as an individual.
Mm-hmm.
And so, do you have any insight on that for these ladies?
So in a survivorship visit, and I'll go into that because that's part of what I do, is I have these hour-long visits. We screen for every type of side effect. So whether you have cardiotoxicity, we ask you if you have shortness of breath going up and down stairs, if you have any new depression, stress, irritability, fear of recurrence, if you have hot flashes, sexual dysfunction, insomnia, basically everything that we've talked about, peripheral neuropathy, joint and muscle pains, we screen for everything and we address everything. Because we have an hour-long visit in the survivorship clinic, which is unheard of for physicians, because they have those 20-minute visits, they have to get through everything, so they may not have time to ask you all these questions or get on that deep of a level. And I feel like that's to our benefit to be able to counsel patients on what their options are, reassure them that this is something that's normal, but it's also something that we can treat. Or something, I shouldn't say something that's normal, something that is expected or has a high chance of being a side effect, and that's something we can try to work out. I don't know if that answered it.
I always encourage ladies to, you have to be your own advocate, and if you're having any of these side effects, you need to speak to your doctor, because almost every side effect out there, there's something we can at least try. Maybe it doesn't work for you, but you should at least try. You never want to give up before you even try. Right. So that's what being a thriver is all about.
Yes.
Is you're not giving up, because you're going to be a thriver. So if something is bothering you, if this provider isn't answering that question, then lots of the hospitals have nurse navigators, or there's survivorship at Nebraska Med. Like, everybody there's someone else other than your physician that you can ask those questions to if you didn't have time in your appointment with your regular oncologist, or even your primary care can help you out with a lot of those things too.
And I always tell patients that, say you're on an anastrozole and that one is just, you're like, I need to come off of it. We don't want you to come off of it. We want to help and be on anything or be on nothing. We want to help find something that works for you. So whether that's trying a different medication, like I said, we don't know if it's going to have any side effects or none, but it could potentially be a lot easier to handle than the current one that you're on. So please talk with your doctors about the side effects that you're having, because there are other options just within the medications that we can give you too.
And I think that's an excellent point, because a lot of ladies don't realize that. They think, I have to take this because I need chemo.
Right.
It doesn't have to be that one.
Right.
You can do better with another one. So, because you have to be functional still during your journey.
Yep.
So, yeah, very much so. When I look ahead in the coming years, what side effects should I look for to be paying attention to other than the cardio ones?
I would say another big one, just because we're talking about usually older women or women that have premature induced menopause, and they're on lots of therapies that are lowering their estrogen, is the bone health. I think that's something that we can easily try to slow down or prevent. Take the vitamin D. Most patients are actually vitamin D deficient. Make sure you're taking at least 2,000 units of vitamin D per day, getting your DEXA scans, because the last thing we want you to do is break a hip. So just make sure that you're doing those things, and that's really a long-term one that we can address easily. I think that one, your mental health, make sure you take care of that. Make sure that you talk to patient or your providers about the sexual health, because it's hard for them to bring up. I know that it's hard for you too, but you can be your own advocate as well.
Yeah, and the sexual health one, you shouldn't really struggle with that, because one thing all of us have in common is that we all, hopefully have a sex life, or want one, or have those desires. So that's a normal thing. So if you can talk about hair loss, then you should be able to talk about, those sexual issues as well. And just to, I know you talked about it briefly, but we had a couple of questions about that in general that were sent in before. So the painful intercourse and the loss of sex drive, the libido being low. Can you tell us some suggestions for the low libidos?
Low libido, So I'm sure you guys have heard of Rachael. Her and I collaborate a lot, and I send a lot of patients to her because she's a sexual health therapist. One of the things that she tells all of her patients and me is try to schedule sex. That sounds awful, but the more that you have sex, the easier or the more drive you'll get. So that's one thing that you can do. So, I don't know, schedule a date night for every Saturday and then maybe slowly increase that to multiple times throughout the week. Even when you have more sex, it will help with the vaginal dryness, it'll help with the pain, and it will increase your libido. So I think that's one of the easiest things that people can do.
So talk a little bit about the dilators for ladies.
Okay.
Where they can get those, what they actually are, and
So dilators are basically comes in a package, and there's different sizes, and they start out very small, and you use one, you insert it into your vagina for 10 to 20 minutes at a time, 2 to 3 times per week, and then you slowly increase the size, and so you'll have all of those in a kit. We help prescribe it so that way you know what you're doing and give you instructions, but it helps expand your vaginal walls, so pain or intercourse is less painful. Yep, we just try to get you back to the normal size that it was before we kind of shrunk down everything with chemotherapy or the loss of estrogen with the endocrine therapies.
And they can actually purchase those at the hospital.
Yep.
In the
So we have it in our Life Renewal Center, and then you can honestly go online as well.
So, can you talk a little bit about the Survivorship Clinic?
Yes. So our Survivorship Clinic is at all 3 locations across Nebraska Medicine. So Buffett, Village Point, and Bellevue. We also do telehealth clinics. They are 1-hour appointments, and what we do is everything's individualized. We look at your cancer treatment, we provide individualized recommendations based off of that for screenings for late and long-term effects, and then we do lots of education. So if you have any questions, we try to answer all of that during that 1-hour appointment. If you have further things that we need to follow up, we will schedule more, or this could just be a one-time appointment. In the Survivorship Clinic, like I said, we do all those screenings, but we also educate you on healthy lifestyle behaviors. So we talk about ways to increase your exercise, to start eating healthier, work on smoking cessation, how much alcohol are you drinking, all of those types of things. And another big part is weight. We really work on weight management and talking about ways to lose weight or maintain your weight at a healthy weight, because we know that obesity can increase your risk for not only breast cancer, but up to 13 other types of cancers.
And so when you say across the clinics, you mean Village Point, Bellevue, and then at the main campus,
Yes.
correct?
Yep.
So you have a survivorship program. And then are you at all 3 of those locations?
I am. And we actually just opened a starting a second program, and it's called the Cancer Risk and Prevention Program. And anybody that's a cancer survivor that has a genetic mutation, say like BRCA, PALB2, ATM, any of those or others, I'm blanking on all of them because there's tons, but they would probably be, or you would be a good fit for that clinic to help personalize screening recommendations to help reduce your risk of other cancers as well.
So, how about insurance? Does insurance cover the survivorship clinic?
Insurance covers the survivorship clinic like it would for your oncologist or another advanced practice provider. So generally, yes, I can't say every insurance is the exact same, so I can't promise things, but we can always check with our financial counselors to make sure if it's covered or not.
Okay. We're getting close to wrapping up, so do you have any other major things that you want or you feel that we didn't cover? Or
I don't think so, but we're going to post the slides with us, and if you want a referral to the survivorship clinic, you can always self-refer. Personally, I love seeing all patients. Breast cancer patients are our biggest population, and I feel like we can help with all of these symptoms that we've talked about today.
So when you say that they can self-refer, that means they do not have to have a physician, or they can be a patient from another clinic and they can still just keep their doctors at their other clinic and they can still come to you for the survivorship program, correct?
Correct. Yep.
Yay.
Yes. Yeah. So we can see anybody.
Can you repeat the name of the new clinic?
Yes. So the new clinic is called the Cancer Risk and Prevention Clinic, and that just opened in July. We see patients 2 times a month in that clinic, and we actually have a multidisciplinary conference to review all patients in that clinic. So we have gynec, breast surgeons, GI specialists, people that specialize in pancreatic cancers, genetics, and then myself, and we all come together to figure out personalized screening recommendations for all patients with genetic mutations or strong family history of cancer.
And I believe that, Rachel, you're also part of developing or leading or one of the forefront leaders of the research program for survivorship at Nebraska Medicine
Yes.
and UNMC as well, right? So
Yes.
that's what I told you, ladies. I love her because she is a difference maker, and that's what I love about her. So that's great.
Yes.
Anything you want to share about that?
So hopefully in 2021 we will have more trials open to cancer survivors to improve quality of life. So it something, I don't know if I should even say these things, but a couple things coming down the road is like health coaching for cancer survivors, how that can improve long-term outcomes, patient and provider shared decision-making trials that are coming, more in the cancer risk and prevention program for pancreatic screening trials. I think there's going to be a lot of trials that are coming up. So those are just a few to name.
So if they're interested in anything about that, how would they find out about that?
They can contact me. I'm trying to figure out the best way. I'll give you my email to figure out trials. Yeah.
So when we post this, we will put Rachel's contact and email information on there as well, so that you ladies will have that. And I hope that you guys gained at least a little insight in our evening tonight. And the mission for Project Pink is to give you tools and knowledge and, you know, the support system that you need to help you become a thriver. And we hope that you got at least one aha out of tonight. And I hope that at some point in time you get to speak with Rachel. You know, if you have questions, please email her, or if you have any other questions that we didn't get to, you're welcome to email me at lbuckley@Project Pink, or just our Project Pink info, and we'll get that to you. So thank you very much for joining in. Thank you so much for giving us part of your evening.
Thanks for having me.
And for our camera crew guys, thank you very much. We appreciate it. And stay safe.